We'll go next slide, please. OCI's mission has both a consumer component and a company component. In addition to helping consumers navigate the insurance marketplace, we also ensure companies are healthy from a financial perspective in terms of having reliably compliant business practices. This helps ensure that Wisconsin consumers continue to have plenty of dependable insurance choices. Next slide, please. So the first sighting of health insurance was approximately in 1929 when large industrial employers created access to health insurance for employees. Next, between the 1950s and the 1960s, labor unions and more individuals began seeking health insurance, typically creating a safety net for catastrophic health conditions. Passage of Medicare was in 1965, and that resulted in one basic program of health insurance for persons aged 65 and older, and another program providing health insurance for people with limited income funded by state and federal sources, respectively. And beginning in the 1970s, there was the concept of managed care through health maintenance organizations. Next slide, please. As we talked about earlier, the principles of insurance are risk and pooling. Risk in insurance is the uncertainty of a financial loss. Risk tolerance is the amount of risk one is willing or wanting to take on by themselves or can afford to take on for themselves. Insurance is defined as a transference of risk. One pays the insurance company to take the financial risk from you to them for a fee called a premium. Typically, the more risk you transfer to an insurer, the higher the premium is for the product, as the potential is greater for financial loss on the insurer. When applied to healthcare, the risk being transferred is the need for medical care during the year. The amount of coverage someone is willing to pay for through premiums may be affected not only by the general risk, but also specific or anticipated risks, such as needing a knee surgery or planning to start a family. Often, you will see lower premiums with group products. The reason for this is the law of large numbers or pooling of risks. Next slide, please. This is the insurance definition of the category for which health insurance falls within. The global classification of disability encompasses the list shown on the screen. These go beyond the typical health insurance, such as medical and surgical expenses, indemnities for loss of income due to accident or health, accidental death and disability, hospital care, and long-term care. Next slide, please. Insurance law follows the state where the policy has been purchased in. An exception, for example, is when we'll say an employer is located in the state of Missouri but has employees here in Wisconsin. There can be times where Wisconsin OCI would have jurisdiction over that health plan for those located here. There would need to be at least 25% of the total number of employees residing in Wisconsin for us to have that jurisdiction. Most disability policies offer a wide range of coverages and limits. The commissioner has the authority to regulate the terms of insurance contracts to protect the policyholder. The insurance laws establish statutory standards that are clear enough to protect the insured and to give the commissioner authority to set specific standards and provisions through rulemaking powers. A group insurance policy is defined as a health benefit plan that is issued by an insurer to or through an employer on behalf of a group consisting of at least 2 employees of that group, including at least 2 eligible employees. Under ERISA, which again was the Federal Employee Security Income Act of 1974, A group insurance plan is defined as an employee welfare plan to the extent that the employee welfare plan provides medical care, including items and services paid for as medical care to employees or to their dependents, as defined under the terms of the employee welfare plan, directly or through insurance, reimbursement, or otherwise. Lastly, a defined network plan is defined as a health benefit plan that requires an enrollee of that plan to use providers that are managed, owned, under contract with, or employed by the insurer offering the health benefit plan. Next slide, please. A healthcare plan means an insurance contract providing coverage for healthcare expenses. A comprehensive health insurance policy offers extensive coverage and acts as a financial pillow in case of medical emergencies. Unlike basic health insurance plans, a comprehensive policy covers outpatients as well as inpatient treatments, including consultations, medical tests, as well as hospital stays. Disease-specific policies provide coverage and benefits only for specified causes of sickness, disease, or injury, such as a heart attack or stroke, and coverage is often limited or, is often in limited amounts or a limited amount of time. Next slide, please. The larger the group pooled together, the greater ability to spread the risk. An insurer can spread its risk for high claims by collecting premiums for more people, which then reduces the insurer's risk and then typically lowers the premium. Health insurance provided to employees by an employer is called group coverage, but health insurance you purchased on your own is called individual coverage. A small employer means, with respect to a calendar year and a plan year, an employer that employed on average at least 2 but not more than 50 employees on business days during the preceding calendar year. The Small Business Health Options Program, or SHOP, Marketplace Plan, helps small business provide health coverage to their employees and is open to employers with 50 or fewer employees. A large employer means, in connection with a group health plan with respect to a calendar year and the plan year, an employer who employed on average at least 51 employees on business days during the preceding calendar year. The 80-20 part of a health plan refers to coinsurance. Your health insurance pays 80% of the total cost of the bill, and you would pay 20% of your total healthcare cost until you reach an out-of-pocket limit. Managed care plans are a type of health insurance. These have contracts with healthcare providers and medical facilities to provide care for members at reduced cost. These providers make up plans network. So, for example, a health maintenance organization, or an HMO, usually only pay for care within their network. And lastly, some examples of the federal programs are Medicare or Medicaid, and some state program examples are Badger Care, Care for Kids, and Forward Health. Next slide, please. A managed care plan is defined as any health benefit plan that requires or creates incentives for an enrollee to use providers that are owned, managed, or under contract with the insurer offering the health benefit plan. Wisconsin statutes define 3 different types of managed plans. They are health maintenance organizations, preferred provider plans, and limited service health organizations. Next slide, please. So the distinctions of managed care plan, simply put, is when a consumer selects a plan with less choices for a network, the premium will be lower versus selecting a plan with more choices, which in turn then mean more in premium. The least amount of choices come underneath an EPO, and sometimes also known as an HMO, and the greatest number of choices usually equal a point of service plan or sometimes under a PPO or preferred provider plan. Next slide, please. HMOs offer predictable cost sharing and administrative simplicity for patients. These features come with fairly restrictive rules about which providers patients may see. An LSHO offer limited range of services performed by providers selected by the organization. PPP or PPO plans provide more flexibility when picking a doctor or network. They also feature a network of providers, but there are fewer restrictions on seeing non-network providers. In addition, your PPO insurance will pay if you see a non-network provider, although it may be at a lower rate. A point of service plan is generally like an HMO. It requires the policyholder to choose an in-network primary care doctor and to get referrals from that doctor if they want the policy to cover a specialist whose services that would be considered out of network. Next slide, please. So this is purely a descriptive slide that shows again when a consumer chooses a plan with less choices for a network, the premium will be lower versus choosing a plan with more choices, which in turn will then mean more premium. Next slide, please. Another way insurers protect against risk is to narrow the coverage options they offer. This time through a specific type of care or treatment they will cover rather than coverage at the provider level. The ones listed here are some examples of those types of plans, such as accident only, blanket accident or sickness, critical illness, cancer only, HIV indemnity, intensive care, hospital indemnity, or sickness only. Next slide, please. Qualified health plans are comprehensive ACA-compliant plans offered on and off the federal exchange. Medicare Supplement and Select policies provide coverage for some of the costs not covered by Medicare Part A and Medicare Part B, as we previously touched upon. Long-term care in general refers to a broad range of services you may need for an extended period of time because of a chronic illness or disability. Long-term care includes medical services, such as nursing care or therapies. It can also include supportive services for activities of daily living, known as ADLs, such as help getting into bathing, dressing, getting in and out of bed, taking medicines, or preparing meals. Care can be provided in a variety of settings, including nursing homes, their home, an adult daycare center, or a group living arrangement with supportive services. We will discuss in a moment here the short-term policies. Next slide, please. As we previously touched upon, these are some of the plans that are generally exempt from our jurisdiction. The self-funded ERISA plans, which again, you'll see a lot of those types of plans with larger employers, such as the Walmarts, the Menards, those types of plans. Labor union and employee welfare plans. Those two types of situations are governed by the United States Department of Labor. A discount plan provides discounts on medical procedures with certain doctors or medical-related costs. These plans are not health insurance in the traditional sense. Medicare Advantage plans are governed by the federal government because they are private contracts between the federal government and the insurance companies. The Centers for Medicare and Medicaid Services, also known as CMS, directly contract with those insurers to provide those benefits. Medicare Part D are the prescription drug plans that are sold separately from Medicare and supplemental insurance or and traditional A and B coverage by the federal government. Healthcare Sharing Ministries were one of the original versions of a GoFundMe, and they have members that share common beliefs and provide funds to each other for medical expenses. And the direct primary care is the healthcare model where patients pay a recurring, usually monthly fee to their primary care physician for a defined set of services, rather than relying on traditional insurance billing for primary care. This type of model emphasizes a strong doctor-patient relationship with enhanced access and longer appointment times with the physician. Next slide, please. So some of the characteristics of short-term limited duration health plans are: they are not required to include specific ACA consumer protections. Some consumers may believe that ACA compliant plans offer and are priced to include unwanted benefits. These short-term plans may offer premiums that are lower than unsubsidized premiums for ACA compliant plans, but they also expose enrolled members to additional healthcare costs in the form of higher cost sharing and/or non-covered services. Price-sensitive consumers lacking full information about ACA subsidies may gravitate towards enrolling in the low premium plans despite their limited coverage protections and high out-of-pocket costs. In many cases, short-term plans may not be the lowest cost option. For the many consumers eligible for the federal premium tax credits and cost-sharing subsidies, ACA compliant plan premiums could be lower or comparable to these plans and offer additional benefits and potentially less cost sharing. As stated, the loss of a short-term plan does not trigger a special enrollment period option back to the marketplace. These policies are often sold as a benefit of an out-of-state association plan, and there are times when we may not have jurisdiction over them. If OCI finds that an insurer or agent represents a short-term plan as compliant with the ACA or providing more than a bridge for coverage and engaging in unfair marketing practices, we will look to take enforcement action. Next slide, please. Insurers selling these plans must include in their marketing materials a consumer disclosure notice as prescribed by the Federal Department of Health and Human Services. To summarize, this disclosure notice states that, number one, the coverage is not required to comply with certain federal marketplace requirements for health insurance, principally those contained in the Affordable Care Act. Number two, be sure to check your policy carefully to make sure you are aware of any exclusions or limitations regarding coverage of pre-existing conditions or health benefits. Number three, take note that your policy might also have a lifetime and/or annual dollar limit on health benefits. Number four, and if this coverage expires or you lose eligibility for this coverage, you may have to wait till an open enrollment period to get other health insurance coverage. Next slide, please. Unlike ACA-regulated comprehensive coverage, short-term plans may limit coverage on an individual's prior health status and pre-existing conditions. They may limit maximum annual and lifetime dollar coverage and lack guaranteed renewability. Many plans also state that conditions that develop under the prior plan with them will then be considered pre-existing. They will conduct post-claims underwriting, and that is where an insurer can review the consumer's medical history, determine that if there was a prior treatment or diagnosis, and use that as a basis to deny a claim. Next slide, please. There are over 100 healthcare sharing ministries certified by the Federal Department of Health and Human Services as meeting the minimum requirement to meet the individual mandate under the ACA. As we've talked about, the member is required to pay any medical bills first with certain health needs to be posted in a newsletter for other members to donate funds to offset the individual's expense. These were considered the original GoFundMe types of accounts, and by definition, they are not considered insurance. Next slide, please. Healthcare sharing ministries are non-insurance entities, which mean they share a common set, in which members share a common set of ethical and religious beliefs and share medical expenses among members in accordance with those beliefs. In a healthcare sharing ministry, members contribute, typically monthly, a payment or share to cover the qualifying medical expenses of other members. The ministry will then either match paying members with those funds, those who need the funds for healthcare costs, or pool all the monthly shares and administer payments to members directly when presented with claims. Next slide, please. Because healthcare sharing ministries are not required to comply with the ACA's consumer protections, coverage for pre-existing conditions may be limited or excluded. Medical benefits are typically far more limited than in ACA-compliant plans, and members are never guaranteed payment, even for covered expenses. They cap out-of-pocket costs and are not required to cover essential health benefits. They can set monthly, annual, and lifetime limits stated as caps on coverage. And lastly, they may charge a higher rate based on health status, and some will deny membership to those that can't pass a medical screen. Next slide, please. So we touched a little bit on these earlier this morning. Again, these are some of the federal laws that we normally have jurisdiction over when it comes to health plans. Medicare is the broad program of health insurance that was designed to assist the nation's elderly. Medicare is available to most individuals age 65 and older, and that particular plan is governed then by the federal government under the CMS. The ERISA is the federal law that sets minimum standards for most voluntarily established retirement and health plans in private industry to provide protections for individuals in those plans. COBRA gives workers and their families who lose their health benefits the right to continue group health benefits, provided that the certain circumstances such as voluntary job loss, reduction in hours, death, divorce, and other life events. Those qualified individuals may be required to pay entire premiums for that coverage. The Newborns Act includes important protections for mothers and their newborn children regarding the length of the hospital stay following childbirth. This requires group health plans that offer maternity coverage to pay for at least 48 hours following childbirth or 96 hours in the case of a cesarean. The Women's Health and Cancer Rights Act is the federal law that provides protections to patients who choose to have breast reconstruction in connection with a mastectomy. This law generally applies to both persons covered under a group health plan and those under an individual health plan. HIPAA was developed in 1996 and became part of the Social Security Act. It assured health insurance portability by eliminating job loss due to pre-existing medical conditions. It reduced healthcare fraud and abuse, and it enforced standards for health insurance and guaranteed security and privacy of health information. MAPIA prohibits group health plans that offer mental health benefits from imposing more restrictive limits on spending for mental illness that are imposed on the coverage for physical illness. The PPACA was enacted to ensure that all Americans have access to quality health care that is affordable and it eliminated the pre-existing clause that prohibited some consumers from being able to purchase a quality health insurance plan. And lastly, the Federal No Surprises Act was effective for services received after January 1, 2022. This protects a consumer from surprise bills for medical services from an out-of-network provider or facility and without prior authorization, like out-of-network coinsurance or copayments, and for all emergency and some non-emergency services. It also provides protection for out-of-network charges and balance bills for supplemental care like radiology or anesthesiology by an out-of-network provider that happens to work in a in-network facility. Next slide, please. The Federal Affordable Care Act, also known as the PPACA, was enacted in March 2010 and was the most significant change to health insurance since the original Medicare Act in 1965. It addresses quality of care, the cost of care, accessibility, and gaps in insurance coverage. Some of the health insurance reforms began in 2010, and some reforms did not begin until 2014. Examples of the reforms include prohibiting lifetime dollar limits and annual dollar limits on essential health benefits, required coverage of specific preventive services with no cost sharing, guaranteed issue of a health insurance policy, and prohibiting pre-existing condition limitations. The ACA provided for the 2014 implementation of health insurance exchanges, also called health insurance marketplaces, a federal website that allows consumers to purchase qualified health plans and determine their eligibility for any premium tax credits and cost-sharing subsidies. The federal government uses the term health insurance marketplace instead of exchange. OCI continues to have regulatory authority over the insurance companies that offer coverage through the ACA. However, we do not have authority over the marketplace themselves since they are a federal entity. Next slide, please. No consumer who signs up for coverage can be refused or have coverage limitations placed, such as a pre-existing coverage clause on an ACA policy. There are 10 minimum health essential benefits required to be covered under the ACA. They are ambulatory patient services, emergency services, hospitalization, pregnancy, maternity, and newborn care, mental health and substance use disorder services, prescription drugs, rehabilitative and habilitated services and devices, laboratory services, preventive and wellness services and chronic disease management, and pediatric services including oral and vision care. In 2026, the amounts listed here on the slide are the most an individual or family will have to pay out of their pocket for coverage expenses under an ACA plan. Next slide, please. Under the healthcare law, insurance companies can only account for the 5 items listed on this slide when setting premiums, and those specifically again are listed here. However, states can limit how much these factors affect those premiums. The ACA provides that comprehensive, individual, and small group health plans be categorized into one of 4 different metal tiers. The tiers represent the average portion of expected costs a plan will cover for the average population. The percentages the plan will spend on average are 60% for bronze, 70% for silver, 80% for gold, and 90% for platinum. There is also a catastrophic health plan through the ACA available to eligible individuals who are age 30 and under and who qualify for a hardship exemption. Bronze plans usually have the lowest monthly premiums, but the highest costs out of pocket when one gets care. This plan is often selected, is usually one who uses few medical services and wants protections from very high costs if they were to get seriously sick or injured. The platinum metal tier usually has the highest monthly premiums but the lowest cost when receiving care. Next slide, please. And now I will pass this on to Sharone. Thank you.
So open enrollment is just the annual time frame during which consumers can purchase individual health insurance plans, either on or off the federal exchange. Excuse me. So for example, a plan sold or amended during the open enrollment period this year coming up would have an effective date of January 1st, 2026. Outside open enrollment, a person can generally only enroll in health insurance if they qualify for a SEP or a special enrollment period. Next slide, please. So as the name implies, SEPs are available for individuals to enroll outside of open enrollment period. There are some basic types of qualifying life events like loss of employer coverage, divorce, change in residence, no longer being eligible for Medicaid, or some other type of life event. Depending on the SEP type, a consumer may have 60 days before or 60 days after the qualified event to enroll in a plan. Next slide, please. So polling question number 1, SEPs allow individuals to enroll in, in the ACA outside of normal open enrollment period when that person, A, decides a different plan would be more cost effective, B, receives a promotion at work, C, loses eligibility for Medicaid, or D, is diagnosed with a severe illness. Give it a couple more seconds. And the answer is C, loses eligibility for Medicaid. Next slide, please. Wisconsin has a competitive individual health insurance market. We have 12 insurers offering plans on the exchange. On-exchange issuers must offer their plans off-exchange as well. So these same insurers plus one additional are offering plans available in the individual market off-exchange. And we have an interactive map on our website where you can look at this coverage. Next slide, please. Under the Affordable Care Act, health insurance companies cannot refuse coverage or charge you more just because you have a, quote, pre-existing condition. That is a health problem that you had before the date of your health coverage. However, policies not subject to the ACA, such as short-term limited duration, fixed indemnity, they can continue to use pre-existing condition limitations. A health insurance company may use different criteria or definitions from what a healthcare provider may use. And obtaining medical records is the insurance company's way of determining whether a condition was or was not pre-existing. Next slide, please. If a consumer or provider disagrees with an insurer's determination, they have the right to appeal through a grievance process. All insurers that issue health benefit plans must develop a, quote, internal grievance procedure. Insurers are required to file with OCI an annual grievance report to show how they've handled grievances during that previous year. The independent review process provides an insured with an opportunity to have medical professionals with no connection to the insurer review a dispute. This is called IRO. IRO has the authority to determine whether the treatment should be covered by the health plan. Next slide, please. The definition of medical necessity is not defined in Wisconsin law. It's defined by the insurance company, and the company's opinion of necessity can differ from the provider's. That's the reason why there's grievance and IRO procedures. It's important to note that health examiners at OCI do not make medical determinations. We're not medical professionals. So, for example, some of the most common complaints we see are differing opinions between companies and providers on the number of sessions necessary for physical therapy or if surgical procedure is necessary. And unless there's a kind of a clear and undisputable violation of Wisconsin law, we tend not to be able to resolve those types of complaints. Next slide, please. The payment of a claim is not overdue until 30 days after the insurer receives the proof of loss required under the policy or equivalent evidence. Also, a delay in payment may be justified if the insurer cannot determine to whom the claim should be paid. The date of payment is the date a check or payment was properly mailed, or if not mailed, the date of delivery of the payment. Next slide, please. So here's our next polling slide. Which of the following is true? A, short-term plans are required to provide coverage for pre-existing conditions. B, QHPs under the ACA are required to provide coverage for pre-existing conditions. C, OCI is able to make medical determinations regarding pre-existing conditions. And D, pre-existing condition limitations may not last longer than 6 months from the date of issue. And the answer is B, QHPs under the ACA are required to provide coverage for pre-existing conditions. Next slide, please. In any state, there can be challenges geographically to ensuring that there are adequate number of providers for the plan's number of enrollees. We have received complaints in the past concerning the number of available providers within an area. Wisconsin statute does not define specifically how many providers must be located within a certain mile radius. So in these cases, we ask companies to work with their members to find providers that fit their needs, or work with them to possibly approve seeing someone outside of the network. The provider can't be found in network. Next slide, please. So the passage of the ACA resulted in changes to standards regarding out-of-pocket maximums. It can sometimes be confusing to figure out what does and does not contribute to out-of-pocket maximum and towards deductible. And so this will be delineated in the policy. Next slide, please. For a consumer to fully understand the cost of their health insurance plan, you must start with the premiums and then discuss cost sharing and add that all together. Remember, the amount out of pocket may exceed the stated out-of-pocket maximum if a copayment does not contribute to meeting the out-of-pocket maximum. And so this will be defined in policy language. For example, a specialist visit copay of $50 may not go to that maximum out-of-pocket. It's very important for consumers to understand that possibility. Next slide, please. So these are generally the type of cost sharing obligations that consumers are going to face. You're obviously going to have your premium. That's just the amount you're paying per month. The deductible is the amount you pay before your insurance company begins covering their end of the costs. A copay is a smaller fixed amount that you pay per visit. It's usually for like office visits, $25, $50, things like that. Coinsurance is a percentage of the cost you pay for a service. So when you hear something like 80-20 plan, 70-30 plan, that's because the insurer is picking up 70%, and your coinsurance portion as the insured is 30%. An allowed amount is the maximum cost your insurance will pay for a service. And out-of-pocket maximum is the the total amount that you're going to be responsible for out of pocket. Next slide, please. Here's another example of how a consumer and company share costs on a policy that runs in the calendar year starting January 1st. So as an example, January 1st, Jane goes to the doctor for an office visit that costs $125. Since she has not yet met her deductible, she will need to pay $125. The plan will pay nothing, but the $125 does get applied to her deductible once submitted to the insurance. We'll say that on July 1st, she goes to the doctor again, and since at this point she has met her deductible, the office visit that costs $75 will now only cost Jane $15, which is 20% of $75, and her insurance pays the rest. On December 1st, Jane visits the doctor again. She has met her deductible, and she's also met her out-of-pocket max. Because of this, the $200 office visit is now paid in full by the plan, with nothing coming out of Jane's pocket. Next slide, please. So the next few slides show a sample found on healthcare.gov of the summary of benefits a company is to provide to its members. So this is kind of just like a general overview of a plan's costs, benefits, covered health services, and other features that are important to consumers. A summary of benefits might also explain the health plan's unique features, cost-sharing rules, significant limitations, and exceptions. And these will all be in easy-to-understand terms. Next slide, please. And next slide, please. And next slide, please. And this is just what one particular SOB might look like. Next slide, please. Health insurance policies sold in Wisconsin also include mandated benefits. These are benefits an insurer must include in certain types of health insurance policies. Next slide, please. Group health insurance policies and self-funded state and local government health plans must provide coverage for mental disorders, alcoholism, and other diseases. This includes inpatient and outpatient treatment for alcoholism, drug abuse, and mental/nervous disorders to ensure that the financial requirements and treatment limitations on mental health or substance use disorder benefits are no more restrictive than those restrictions on medical or surgical benefits. Group health policies are required to provide coverage for transitional mental health, alcohol, and other drug abuse treatment arrangements, such as day hospitalization. HMOs, in addition to covering the mental health services described above, are required to provide certain benefits for outpatient treatment of nervous and mental disorders, alcoholism, and other drug abuse to a dependent student who is attending a school of higher education located in this state but outside the HMO service area, if the HMO would have provided benefits for such services by a selected provider within the service area. Next slide, please. Preventive care services are not subject to cost sharing when delivered by a doctor in the insurance network. For high deductible plans, first dollar coverage is only available for certain preventive care benefits, such as an annual physical. And for a list of preventive services, you can go to the U.S. Preventive Services Task Force at the URL listed on the slide. Next slide, please. COBRA is the federal law allowing most employees, spouses, and dependents who lose their health coverage under an employer plan to continue coverage at their own expense for a period of time. COBRA applies to insured health plans and self-funded employer-sponsored plans in the private sector, and those plans sponsored by state and local government, and it applies to employers that have 20 or more employees. Next slide, please. Wisconsin's continuation law applies to most group health insurance policies providing hospital or medical coverage. The law applies to group policies issued to employers of any size. Additionally, employees who live outside of the state of Wisconsin during employment with an employer located within Wisconsin would be eligible for continuation coverage. The law does not apply to self-funded health plans or policies covering only specified diseases or accidental injuries. When both laws apply to group coverage, it's OCI's opinion that where federal and state laws differ, the law that is more favorable to the insured should apply. Next slide, please. So key points here are separation from the employer cannot be for gross misconduct, and the individual continuing insurance must pay 100% of the premium. You may be asked, am I eligible for a special enrollment period under the ACA if I decide to drop my continuation coverage or I stop paying premiums during the 18-month eligibility period? The answer is no, you are not eligible for a SEP if you voluntarily cancel your continuation coverage before your 18 months of eligibility have been exhausted and you are outside of the annual open enrollment period for health insurance. And it is the responsibility of the employer to notify the enrollee of their continuation rights. Next slide, please. And again, here's a list of some OCI resources on all of the points that we've discussed. Thank you very much.
Perfect. Thank you so much, Shelly and Sharone. I'm going to see if we have any questions. Right now, it doesn't look like we have any. We'll give it a few minutes in case anybody wants to type in some questions that they may have for Shelly and Sharone today. I also would like to mention that Adam Van Spankeren at Covering Wisconsin and I will be hosting an office hour on September 12th at 1:00 p.m. There is a Zoom link that we will put in the chat that you could join if you would like clarifications regarding licensing or training, or information that you've learned about during the next 3 days. We will put the link to the office hour every day from today until Friday. We will give everyone a few more minutes to submit any questions that they may have. Okay, it does not look like we have any questions coming through. So we will begin again tomorrow at 8:30 in the morning. We will have a presentation from Shelly and Sharone about the Affordable Care Act for navigators and certified application counselors. And then there will be a two-part session by Adam Van Spankeren about healthcare.gov applications, doing a walkthrough of the application, and also going over special enrollment periods. Thank you all so much for joining us today, and I hope you have a great day, and we will see you tomorrow.